Hello everyone, and welcome to today's webinar. In today's webinar, we will be exploring the psychosocial challenges, the mental health and resilience in aging and older people living with HIV. My name is Mario Cascio. I'm a person who has been living with HIV for over 40 years now. And as EATG's Program Chair for Quality of Life, I will be moderating today's event. So next slide, please. Well, this is the last of a series of webinars. Can you go? The last of a series of webinars, which are part of an EATG community-led research project investigating the policies and interventions across 7 WHO European countries, addressing the clinical, the psychological, and the social complexity of older people living with HIV, and how these policies and interventions align with the Glasgow Manifesto. The findings of the research were launched in Paris a few weeks ago, and for those interested, they are available on our EATG website. Next slide. But before moving on with the presentations, just a few housekeeping rules. The event will be recorded. It will be made available on the EATG's YouTube channel. During the presentations, make sure that you are on mute mode, and you can write any comments or questions directly in the chat box. Questions throughout the meeting can be asked in the chat, but if you would like your questions to be anonymous, please send them in a private message to Natalia Gerasimchuk, and we will not disclose your name. And then finally, please click on the More button at the bottom of your toolbar, which is the 3 dots, where you see the 3 dots, and you must choose interpretation, which is the icon with the globe, and from then select your language, which could be English or Russian, because we are having a Russian translation here today. Please do not stay on the original general channel, because this would create some problems with the audio, for example. And finally, during the Q&A sessions, questions or comments about the content can be asked by clicking on the raising hand option. And if you are experiencing any technical issues, please contact the Apostolus. Next slide, please. So we're honored to have with us today a great group of expert speakers who will be sharing their insights and expertise with us. Amy Vera, Giovanni Guaraldi, Maria Jose Fuster, Joe Josh, Kate Murcin, and Anton Bazenko. Each of our speakers brings a wealth of knowledge and experience, and we're excited to have them here sharing their experience with us. Well, let's give them a warm welcome and let's get started. Our first speaker is Amy Vera. Amy is a professor in HIV medicine and head of Department of Global Health and Infection at Brighton and Sussex Medical School. He is also a consultant physician for the Lawson HIV unit at the Royal Sussex County Hospital in Brighton, where he is the lead physician for the combined HIV and geriatrics and memory clinics. Amy's research focuses on the study of comorbidities affecting people with HIV and the development and evaluation of innovative models of care for people living with HIV with comorbidities and memory impairment, including interventional studies aimed at improving quality of life and mental health of older people living with HIV in both low and high income settings. His presentation will focus on the experience of his team managing complex older people living with HIV through the integration of frailty screening and comprehensive geriatric assessment into routine HIV care. He will share practical insights, challenges, and successes, and explore future directions for developing sustainable and adaptable models of care that address the unique needs of aging populations living with HIV in diverse healthcare settings. The floor is yours, Amy.
Thank you very much, Mario. Let me just share my presentation, and then we can start. If that's okay. Can you see it there?
Yeah.
Okay, let me just go.
If you can put it full screen.
Yep.
Perfect.
Thank you very much for the invitation, really, to come and talk about this important area, which is psychological challenges, mental health, and resilience in aging and older people with HIV. As Mario was saying, I'm a clinician academic, and I have an interest, particularly in the management of aging and older people living with HIV. In Brighton, we've been kind of at the forefront of developing new services to kind of address these issues. But I think in my presentation today, I just really want to kind of dig down a little bit more about what mental health, what brain health, and what actually resilience means in people with HIV, and what are those challenges that we all have, not only individuals, but also healthcare professionals and services to be able to deliver the care that patients actually need. So let's start with just something very, very simple. I mean, what is mental health and what is brain health? And I think a lot of these concepts tends to be kind of mixed up sometimes. And I'm talking about not only among people living with HIV and the general population, but even among healthcare professionals and academics. So mental health, and there are lots of different definitions out there, and I'm kind of getting some definitions from kind of WHO and so on, is really a state of mental well-being that allows people to cope with the stresses of life, and we all have those, being able to realize their abilities, being able to learn well and work well, and also contribute to their community. So mental health is just as important as physical health is, and it's an integral component of health that obviously help us as an individual to be able to kind of make decisions in what it is a collective, help us to kind of build relationships and shape the world that we live in. So it is a basic human right, and it is absolutely essential to personal, community, and socioeconomic development. So it's so critical, and it is interesting that sometimes governments don't pay too much attention to mental health, and for many, many years it was actually neglected, if not still neglected in many of the settings. So really, it is more than just the absence of mental disorders, which is the more biological way of thinking about mental health as just mental illness. So what is then brain health? And brain health is slightly different. Brain health, as a definition, is more about the state of brain functioning. And we're talking here about around different areas like thinking, for example, where you're thinking about memory, concentration, attention. We're talking about sensory, socio-emotional, behavioral, and motor domains. So it's more about how the brain is functioning, right? And again, it's about allowing, because of function, allowing a person to kind of realize their full potential over the life course. And again, that's irrespective of the presence or absence of any disorders. So let's just try to kind of summarize this a little bit. So mental health really is about how we feel, how we think, and how we function socially and emotionally. And brain health is how well the brain as an organ functions across different domains. And again, the domains, the brain is a very complex structure. We're talking about things like memory and thinking. We're talking about sensory, motor, even how we move and how we do things, but also the social emotional part of it. You can start seeing that it's kind of cross integrating with what mental health is and determines our behavior. So really, these things cannot be seen separate. There is a lot of interlinked dimensions of both mental health and brain health. And sometimes when we are developing services and when we are addressing a particular issue, like a problem with memory and concentration, for example, we need to consider mental health issues too, because they might be not only the cause of it, but also they need absolutely critical for the management of those. And if you look at the different sort of neurocognitive models that are out there in terms of what happens to the brain, and you start looking down about some of the different sort of mechanisms that might be involved with things like brain health, for example, and similar the mechanisms associated with mental health, you realize that there are different factors. So it's very much multifactorial. There are lots of different factors. And I want to highlight some of the ones that perhaps we started noticing a lot more, particularly since COVID. And we're talking about these social determinants of health, because we know that many of the differences that are between people with HIV and people without HIV might not necessarily be related to the HIV or the medications themselves, but the fact that our patients tend to have social determinants of health that makes them more vulnerable and therefore more prone to actually have poorer outcomes. Things like discrimination, things like HIV stigma, things like the fact that many of our patients are vulnerable, they are more financially insecure, and therefore have more chances of actually having a good start or good reserve when they start facing some of these more physical problems. So social determinants of mental health are absolutely critical. And this is, I just quite like this cartoon because it kind of highlights some of the difficult issues. And as a clinician, I get a patient that comes to my service with mental health symptoms, and we do a screening for mental health. And I know that they have some mental health issues, but unless I explore a lot of these issues here, it's very difficult for me to be able to offer something that is really going to have a difference. Giving an antidepressant might not be enough if someone is poor, doesn't have good housing, and is not eating properly. That doesn't really matter that much giving an antidepressant. It's very likely that the outcomes are not going to be the best. So we need to kind of really explore the social determinants of health and try to support patients and develop services that can support patients to ensure that they have a better sort of outcome, whatever outcome it is. So what is the issues about mental health in people with HIV? What is going on? This is just to give you an idea about the magnitude of this problem. And I got to be really clear that a lot of the data that I'm going to show you right now mainly come from the global north and mainly from Western, the Western sort of global north, if you like. If we look at the frequency of mental health challenges, you can see here that people with HIV are at least 3 times more likely to have mental health problems compared to the general population of those settings. We are talking about rates of prevalence of anxiety, prevalence of depression, and also sleep disturbances, which we kind of put together into this as neuropsychiatric symptoms. So it is a big problem. We tend to kind of, if we ask our patients, we tend to kind of find a lot of this. So what is the situation across Europe? And I think across Europe, in terms of people with HIV, again, you tend to find that about 20 to 35% of people with HIV meet the criteria for major depression. And in many of these cohorts, it's even more in terms of anxiety and depressive symptoms when you actually go and start looking for this. And I think if you compare that to the kind of prevalence within the sort of general population in Europe, you can see that the difference is quite significant, about 6%, bearing in mind that there is some variability in terms of the reports and the prevalence of this condition. But I think it is clear that, at least in the context of Europe, mental health in people with HIV is a big, big issue. And I think it's something that needs to be addressed in terms of the services that we're developing for our patients. But there is a lot of inequalities here, even in the reporting. And this is some work that one of my PhD students did. We did the same for aging research. So actually what you're seeing here is very similar to what you would see in terms of aging research. And it's that most of the research is coming from certain places, mainly the global north. And a lot of the research is done mainly in men. A lot of it in men that have sex with men of white ethnicity. So we need to be very careful about how we interpret the data depending on the setting that you are. And definitely it's very important to kind of try to do studies within the settings that you are to be able to understand what are the specific factors that perhaps are not that relevant for you if you are, because a lot of the data that we see tend to come, for example, from the US. So if you are living in Eastern Europe, perhaps those factors are not going to be as relevant or as clear as you might think. And just to give you an example, this is really hot off the press, not quite. This is some analysis that we've done in 3 different African nations, Uganda, Kenya, and Nigeria, looking at over 3,400 individuals. And that were followed up for about 11.5 years. And these individuals had a baseline, and every 6 months, the clinical epidemiological scale for depression, which essentially looks for depressive episodes. And a score that is about 16 suggests that people are more likely to have clinical depression. And you can see here that at baseline, a lot of the people were quite young, and a lot of them, people with HIV, have more depressive symptoms overall over the 11.5 years compared to people without HIV. But what is interesting is that actually there is no really significant difference in terms of the time to first depressive episodes between people with and without HIV, suggesting that the factors that you see in the population in the global south might be very different, and that the rates of depression and anxiety might be different compared to the population in the global north. Now, you look at what are the factors that are driving this, you realize that a lot of these factors are things that are socioeconomic factors. And some of them, you see here, these lines, yes, over here, everything that is kind of significant or detrimental, and over here, everything that is kind of protective. And you see that if people, smoke, they don't have enough to eat, they have issues about domestic violence, that are factors that are gonna lead towards more depressive symptoms. And if people complete the secondary school, if they have food to eat, if they are employed, if they have enough food to eat, these things are gonna be more protective. So there are factors of resilience and factors that are detrimental for mental health. And that's very similar to what happens also with memory and concentration. This is just to highlight how important social determinants of health really are. And the fact that when we're looking at mental health, when we're looking at brain health, cognition, memory, and so on, we need to look at all these factors, not only the biological factors. Yes, the HIV might be a factor. Yes, the medications might be a factor. But our patients are older and they have lots of different comorbidities. And yes, there are some medications that might be associated with side effects, but that's not all. We're looking at the psychological factors. We're looking at social factors in terms of stigma and discrimination, poverty, and so on, and also structural factors that are so important in terms of how we are delivering care and perhaps exacerbating some of the inequalities. So our population is very diverse, right? Of people living with HIV globally, very, very diverse. And if you look at the challenges that a lot of these key populations can experience, can be very different depending on where you are. And this is some work from, well, I'm going to try a little bit here about the British HIV Association's standards of psychological support for people with HIV, which are under consultation at the moment. Kind of highlights very nicely some of the challenges that each of these communities can experience within one single country. This is a busy slide. You will have time to kind of look at this, but you can see here that, if you are Black, if you're a man that has sex with men, if you're a person that injects drugs, transgender, or a young adult, or a woman living with HIV, you have challenges in terms of how you, experience accessing care and also the issues about mental health specifically. So it's very important that we do that. How many minutes do I have, Mauro?
Can you speak now? Can you speak a little bit slower for the translator, please?
Sorry, I will speak slower.
Okay, thanks.
So it is complicated. It is not easy. It's not easy for individuals that have to navigate services and symptoms, and it is not easy for healthcare professionals that also have to kind of navigate the services and provide care when many of the HIV services don't provide this care. But let's talk about resilience, because resilience is very important, and people with HIV are very resilient, particularly aging and older people with HIV. When I'm talking about resilience, it's about the ability to adapt positively to adversity, stress, and trauma. We do this on a daily basis. When things don't go well, we just don't panic. We, in many ways, trying to kind of be resilient and trying to kind of overcome those issues. For people with HIV, resilience might mean different things for each individual. It might be about managing stigma, coping with a chronic illness, adhering to lifelong treatment, which is not easy, and trying to kind of maintain emotional well-being despite all the challenges that people have. This is just a piece of work that we did during COVID, just looking specifically at the impact of COVID on kind of health outcomes, service accessibility, but also psychological well-being among people with HIV. And it was something interesting here in terms of that many people with HIV said that actually HIV helped them to be able to become more resilient during the sort of COVID-19 pandemic and being able to cope with the situation. So there is a lot of resilient reserve in our patients, particularly older people living with HIV, and we need to capitalize on that. So if you look at the sort of resilient resources for people with HIV, is looking at all levels, from the individual, how can we make sure that our patients are optimistic, have the right coping skills and the right kind of resources to develop resilience. Interpersonal, in terms of, peer support networks, for example, that are so important, safe environments for them. issues about community and organization, for example, how we ensure that our services start providing access to mental and psychological health and support that patients need. And also looking at policies. So important that we can integrate HIV and mental health care, because I think our patients really struggle going to generic mental health services, and access is always very, very difficult. And it's not great. This is some studies that we did in the POPI cohort, and the POPI is a cohort study of older people living with HIV over 50 years old. And if you look at the cascade of care overall for all people with HIV accessing services for depression is quite grim. In theory, we should have 100 people that have depressive symptoms being able to access mental health care, and you can see here that actually the numbers are quite grim. We have problems with access. It's a reality. We need to kind of sort this out. It's so important. And if you look at this report from the National AIDS Trust about HIV and mental health, you can tell why. And it just shows that there are issues. There are lots of gaps in terms of lack of HIV knowledge and understanding within psychological services. There is no good integration with HIV services to make sure that we serve these populations really, really well. And you can just see it here in terms of when we ask the question about whether the clinic have in-house psychological support, you can see that only about 37%, at least in the UK, cannot do have this type of support. And that's quite high. And I know that in many places in Europe, that is not the case. And in small services, even within the UK, that is not the case. So as a response to this, I think the British HIV Association started developing these standards of psychological support, which I invite you just to kind of have a look and perhaps thinking about how these principles and standards is what is needed to be able to start this integration of HIV and psychological care. And it's really simple things like promoting mental health and well-being, offering comprehensive services, engagement of people with HIV, support with diagnosis, case finding and screening, identifying those needs, making sure that our staff is well trained, particularly psychologists, to understand the nuances of HIV, coordination of care, and also based on evidence-based practice, which is so important and so relevant here. So it's all thinking about what standards are needed to preserve mental health and help brain health too, because these two come absolutely together. So if we're thinking about integration, what are we thinking about? We're talking about screening for mental health issues, training, clear referral pathways, making sure that we embed mental health professionals within HIV clinics, that they are part of the clinic too, that we have peer support available, and that the voluntary sector is involved and can help us to bridge those gaps, because some patients don't necessarily want to talk to healthcare professionals about their problems, but they will be able to open up with a peer supporter. And important recording of HIV status in mental health settings to enable better coordination of care and making sure that we facilitate that so patients feel comfortable disclosing their HIV status within these services. So self-management is important, and we should encourage that. Yeah, and we should encourage that. So these are just some ideas about what we can do in terms of self-management. And just to say that, there are lots of publications there suggesting what patients with HIV could do in terms of being more proactive about mental health and so on. And there are lots of resources out there that we could potentially use for that. This is just an example of something from my group in terms of providing patient services and information about HIV and brain health. Very happy to kind of explore it and look at it. And that's just my final summary, really. It's about how important mental health is, and the importance of resilience, and the importance of mental health services being able to provide for all. And I'm just going to finish with this. More about resilience is not about avoiding the storm. It's impossible to avoid the storms, but it's about learning how to dance in the rain. And with that, I'm just going to finish my presentation, and thank you very much for listening.
Thank you, Amy. It's a very, very inspiring presentation. And I'm always impressed by those numbers, seeing, the compared to the general population, the prevalence of anxiety, depression symptoms, and so on. Well, we can talk about this probably during the Q&A session. So I'll move on to our next speaker, which is Giovanni Guaraldi. Giovanni is a full professor of infectious diseases at the University of Modena and Reggio Emilia in Italy. He leads the Modena HIV Metabolic Clinic, which is a multidisciplinary, people-centered clinic where 4,500 people living with HIV have been evaluated for comorbidities and frailty in a multidimensional description of aging trajectories. In 2000, he founded a large liver and kidney transplant program for people living with HIV, and more recently, a long COVID clinic where 1,500 people are in charge. In 2020, he was involved in early studies addressing treatment of acute SARS-CoV infection, and he started a multidisciplinary long COVID clinic where approximately 1,500 people with so-called long COVID are followed up. Giovanni has widely published over 500 papers on various clinical aspects of infectious disease treatment and care, and he is a panel member of the European AIDS Clinical Society guidelines. The floor is yours, Giovanni.
Thank you, Mario, for this kind introduction. You see, I think this is the last of a beautiful series of webinars taking care about the unmet need of older people living with HIV. But I suggested, Mario, today to look not just at the need of older people, but also the psychological and the social need of caregivers of taking care of older people living with HIV. Well, first of all, I think that we don't need to repeat again the fact that the population of people living with HIV is rapidly aging, and this demographic shift demand a new perspective on comprehensive care. And actually, this need were formally articulated in the Glasgow Manifesto that was issued in 2022 by the International Coalition of Older People with HIV, the ICOPE-HIV. And here, actually, among the speakers, there's really the writing members, the people that really did this incredible job just to strengthen the need of care, of quality of life, and empowerment whenever we face the aging issue. But while the Glasgow Manifesto really powerful centers the voice and the need of people aging with HIV, the vital role of caregivers have received limited attention in research and in policy discussion. And my point is that these caregivers are really essential partners in achieving the manifesto vision, providing comprehensive care, enhanced quality of life, and empowerment. If we do not have on board all these caregivers, actually the aim of the manifesto cannot be reached. Who are the caregivers of older people living with HIV? Well, first of all, are family caregivers. They are the partners, the adult children, the siblings, and the extended family members who provide daily support and advocacy. And these family caregivers are most of the time themselves older people living with HIV, and of course this creates a unique dynamic of mutual care and shared experience. But also they are institutional caregivers, and they may be doctors, they may be nurses, they may be social workers, and now more and more people working, healthcare provider working in long-term care facilities who deliver clinical services, but also who coordinate the medical care system and help to navigate the complex treatment protocols. But also, I think we need to rediscuss what is the role of the community, like peer advocates, like volunteers, but members of patient organization. I think today there's a lot of them represented in this webinar, and I think that they are crucial in providing support, emotional support, education, but also really engagement opportunity for all this. So I think it was really important to listen the voice of all these people. And in order to understand what were the caregiver experience, Actually, we built a study. The study is called the Healthy Aging Research and Action for People Living with HIV. This was a national initiative that was founded by the Italian Ministry of Health. I had the privilege to coordinate this with my metabolic clinic, working together with 12 national associations that were able to conduct a focus group, both in people living with HIV and in caregivers that were interviewed in order to explore the lived experience, the daily challenge, and the unmet need, and also resilience strategies of caregivers supporting older people. Well, through a reflective thematic analysis, we identify 6 interconnected themes from our focus group. Well, try to read and understand which are the most important themes that came out from these caregivers. And so first of all, the number one is still managing aging as stigma. Remember that all stigmas are somehow interconnected, but actually what I think is the last pillar of stigma is in fact ageism. That is the discrimination, the way in which we feel, the way in which we act towards age. And actually this is very, very common in our society, but is really common and particularly perceived in people living with HIV. And we will try to understand how we can cope with this issue. The second issue that came out is really surviving with HIV, but really what is needed is how to balance a survival mode with actually quality of life and also moment of joy. And so we need to have a perspective of healthy aging, of making aging be a happy experience. And so I think this balancing of managing comorbidities, of disability, of health issue with all this is very much important. Another issue that came across was, in fact, the housing and the community problem. Actually, what was found, it was that, in fact, more and more there's an issue where to spend the last part of our life. And so people are very much worried where I will be living, when I will no more be self-sufficient. Lots of people are really afraid about entering long-term care facilities, but also not just that, but also how to meet with the other people. What are the spaces, the free spaces, the HIV competent spaces where people with HIV can meet, can discuss, and also can share their experience. Then the burden of care. We know that actually aging most of the time is associated with a big issue with regard of having many special visits, specialty visit, and actually navigating with a healthcare system is also a very exhaustive experience, and most of the time the disease in the hands and the shoulder actually of caregivers and caregiver responsibility. Another important issue is the gratitude of being living in older age with HIV. Of course, this is a gratitude experience thanks to the availability of incredibly good antiretroviral therapy, but actually there is still the mix of survival guilt, because most of all the people living with HIV are people that survived from HIV, and actually many of their friends, of their relatives actually died because of this. And so managing this gratitude mixed with guilt is really something very difficult to manage from a psychological point of view. But also, and last but not least, there is the themes related of death, of dying. And of course, we all die when we get old, but actually it's so much important that we rethink how dying at an older age in people living with HIV is different than what was dying when you were young with AIDS. And actually, we still need to think what is a dignity in the way we die, at an older age. And actually all the themes regarding the way in which we can provide dignity in death is so much relevant. Well, let us now see very shortly which are the burdens of a different caregiver group. I will just quote one for each that has emerged in our focus group. With regard of family caregiver, the most important issue that came out was, in fact, the stigma and the ageism. And what family members most of the time brought out was the issue of a generational knowledge gap. Caregiver really responded that there is a huge variation in HIV literacy among healthcare providers, but actually that was strange to me, but actually what came out, it was some concern gap, particularly evident among younger clinicians, and actually the idea that, for instance, the U equal U literacy is still quite, let us say, not universal. And actually, the new generation of doctors and of healthcare providers seems to be less sympathetic most of the time, less interested in the managing of people living with HIV. And as a professor at universities, I really face the issue of how to engage a new generation of doctors and nurses to be involved in HIV care and HIV research is something that is perceived to be less attractive than what have been in the past.
2 minutes, Giovanni, 2 minutes.
Yes. What about institutional caregiver burdens? Well, I think there is an emotional dimension because of the fact that caring for residents make a great emotional strength that is producing fatigue. There is also an existential dimension because, of course, facing death produce let us say, difficulties because you ask yourself to question about the meaning, the purpose of what you are doing. And of course, there's a professional dimension because you need really to know about palliative care and emotional skill beyond the job role. And last but not least, there is the role of the community. And actually, I think that we need to rethink how the community may reorganize the way in which they provide social support, but also education and advocacy in a person-centered, age-inclusive care model. And so I think that this is a good time in which many of you working in patient organization may rethink what are the services that are now needed in all this. Let us conclude just to think which are the translational implications, which are the action that we can do. And so at a practice transformation, I think that we need ourselves to rebuild the healthcare. We provide all the people. Imagine, for instance, the integration of geriatrician, social workers, and mental health providers. People like Jamie are so much important in our clinic so that to address all these issues. Also, we need to provide protocol of managing multimorbidity and polypharmacy because of the high prevalence of this condition, but also, again, create a cognitive assessment for aging population. Move to policy innovation. Well, I think we need to think that caregivers are needed. Maybe you need a compensation because of the fact that actually we understand that they are simply needed. They are essential. And also we need to think how to help them, for instance, simplifying the bureaucratic pathway to service and resources that they complain to be so time-saving, so time-consuming, but also community empowerment. And so I think that we need to found for peer-led support group for older people to support advocacy training and create, this is so much important, intergenerational mentorship program to preserve community wisdom. And so this is my take-home message. I think that really we need to transform caregiving from an act of individual sacrifice into a model of collective support. And so really we needed to think that any supporter caregiver strengthen the entire network of care. Please recognize what is the role, what is the importance of caregivers in the pathway of healthy aging for people living with HIV. Thank you.
Thank you, Giovanni, and thank you for raising this issue about the caregivers, which is something we don't really think about usually. And also about the fact, I mean, that community organizations should have, let's say, a discussion about what services they can provide. I mean, we have historically provided services to people living with HIV, but now we are, let's say, we should start providing services to older people living with HIV, which are a bit different than the things that we've done in the past. So I'll move on to our next speaker, which is Maria Jose Fuster. Maria holds a PhD in social psychology and a master in methodology of behavior and health sciences. The main topics of her research are the psychosocial problems associated with HIV, including stigma, health behaviors, psychological well-being, and quality of life. Furthermore, she has knowledge and expertise in the design, validation, and application of patient-reported outcome measures. In addition, she has a long history of activism and collaboration with Spanish NGOs and scientific societies working in the HIV response. This has enabled her to conduct several multidisciplinary HIV research projects following the community-based approach principles in Spain. And also, she is a woman who has been living with HIV since 1989. She is a member of the executive board of the Spanish AIDS Society, SAICIDA, and professor of the Department of Social Psychology, Faculty of Psychology, UNED in Madrid. Maria, the floor is yours.
Thank you very much, Mario, for your kind presentation, and thank you very much for inviting me to participate in this webinar. We are here because we know that the number of older people with HIV is increasing rapidly, and it means that we must rethink health and care priorities to address the unique needs of this group, which is our group, my group, and Mario's group also.
Yeah.
So,
Absolutely.
Absolutely. One of these needs is mental health burden, and as Jaime has shown, the prevalence of mental health problems such as depression, anxiety, suicidal thoughts, and insomnia are extremely frequent among people living with HIV. Also, data showing this systematic review demonstrate that mental health conditions like depression and the other disorders are much more frequent among people living with HIV than in the general population in this case from UK. But what happened with mental health in older people with HIV specifically? I have reviewed some systematic reviews and confirmed that older adults with HIV in Europe and in the United States face elevated rates of mental health problems compounded by stigma and barriers to appropriate care. The research underscores the urgent need for routine mental health screening, integrated multidisciplinary care, and intervention to combat social isolation and stigma. This slide explains that older age is a key risk factor for developing neurocognitive disorders among people living with HIV. Jaime Vera has also explained it. And research shows that as people with HIV get older, our chances of experiencing cognitive decline, such as memory or concentration problems, increase significantly. Now I am going to quickly review some factors linked to mental health and its consequence. And we know, and Jaime has explained also, there are multiple factors linking HIV and mental health. This slide illustrates how HIV infection can directly affect the central nervous system through the virus itself or through treatments, leading to neurological and inflammatory changes that contribute to psychological stress. But at the same time, psychosocial factors like discrimination, lack of support, and others, determinants, so mental determinants of health or social determinants of health, have a major impact on mental health for people with HIV. Together, these biological and psychological pathways reinforce the risk of developing depression, highlighting the need for integrated care that address both medical and social needs. This slide is a study conducted in the general population and explains that how we perceive aging has a real effect in our longevity. In a long-term United States study, people from general population with a positive self-perception of aging live longer than those with negative perception. These results lead to the World Health Organization to identify the fight against age-related stereotypes as a priority, since negative perception can directly harm health and survival. In the same long-term study, Levy et al., that are the authors of this study, found that people with a negative self-perception of aging had higher C-reactive protein levels, which is a marker, as we know, of inflammation, and this was associated with higher mortality over a 6-year follow-up. In fact, more than a quarter of those with negative aging perceptions had died, compared to only 13 of those with a positive self-perception of aging. Loneliness is also a big challenge that people with HIV have to cope with. Loneliness is much more prevalent among older adults with HIV in Europe compared to the general older population. Loneliness in older people with HIV is associated with poorer physical and mental health outcome, a faster decline in daily functioning, poorer adherence to treatment, and higher risk of mortality. In this slide, I summarize how poor mental health deeply affects people with HIV. It increases the risk of not following treatment, leads to worse health outcome and hospitalizations, and raises the likelihood of dying from other illness. Mental health problems can reduce life expectancy by 10 to 20 years, making integrated care, of course, essential for this population. It's a reduce in the life expectancy of general population. I am not talking here of specifically people with HIV, are the data from general population. Now, I would like to address some specific challenges that faced by people with HIV and how we can experience psychological growth despite of it. Women living with HIV, that is a population that is very important for me, face unique mental health challenges, especially around menopause. Many face intense physical symptoms, urogenital problems, and high level of psychological distress. These high rates of symptoms indicate a strong link between menopause, HIV, and mental health. So it is critical for clinicians to recognize these overlapping needs and ensure that women with HIV receive not only medical care for HIV, but also tailored support for both menopausal and psychological issues. In this sense, it is essential to highlight the importance of hormone therapy in managing menopause for women with HIV. I am now an activist in menopause and hormone replacement because of my age and my own experience. But despite my personal experience, multiple studies point to a knowledge gap that many women and healthcare providers lack information about hormone replacement therapy and its potential benefits. Improving awareness and access to hormone therapy could play a key role in preventing metabolic complications and enhancing our quality of life. AIDS survivors are another group that face unique mental health challenges. Many long-term survivors show symptoms like complex post-traumatic stress disorder, with ongoing issues like anxiety, low self-esteem, social isolation, and depression. However, there are ways of coping, like activism, that can provide positive personal resources to people with HIV. The study displayed in this slide found that many HIV activists experience high level of trauma, but also personal growth. Post-traumatic stress disorder and depression were common, but strong self-confidence and a sense of unity with the activist community helped many cope and even thrive, showing both the risk and resilience built through activism. Resilience, as Jaime has explained, is the ability to overcome, adapt, and respond to adversity. In older people with HIV, resilience plays a key role in maintaining quality of life despite ongoing psychosocial and medical challenges. A recent systematic review that is displayed in the slide found that personal resilience resources like trait resilience, spirituality, and self-efficacy act as protective factors and are strongly linked to better well-being. So supporting and strengthening resilience should be a priority in intervention, not just for coping, but for actively improving quality of life in those aging with HIV. But how we can build resilience? The process starts with motivation, that is finding hope, accepting oneself, and seeking support from others. The next step is HIV management, which means practicing both physical and psychological self-care. And finally, mastering the disease involves regaining control over your life, feeling empowered, and making choices that support long-term well-being. Together, these steps empower people to move from merely coping towards true resilience and self-determination. In conclusion, older people living with HIV face complex medical and mental health challenges, with stigma and gender making things harder, and addressing mental health, building resilience, and providing strong community support are essential for healthy aging. Comprehensive integrated care will improve outcome in this population. Finally, in this slide, I review what is working well in Europe. Regular mental health screening in HIV clinics, team-based care, community support, and anti-stigma efforts. Yet, major challenges persist. We know that late diagnosis in older adults persist, lack of mental health resources, and ongoing aging and HIV stigma. Overcoming these barriers will require political will, active involvement from affected communities, and model of care that are adapted to the needs of older people with HIV. So thank you very much for your attention. And again, thank you for inviting me to participate in the webinar.
Mario, your mic is on mute.
Okay, thank you, Maria, for your presentation, and thank you for raising the issue of loneliness among older people living with HIV. I think this is an aspect, the prevalence we see is much higher, but it's an aspect which, reflects also on the health outcomes and so on, and also about the complexity of care and the connection with mental health problems in women in menopause, for example. So now I'll move on to our next speaker, who is Jo Josh. Jo is a communication lead for the British HIV Association. She's an experienced communication professional working in print and broadcast media and crisis management in HIV and pain research. Since 2017, she has managed communications with media, health system, government, and the HIV community on behalf of BIVA, which is the British HIV Association. And she does this on a freelance basis. She was a member of the working group that updated its recently published psychological standards. She is also a regular speaker for organizations including NAT, THT, and UK CAB, and also co-chairs the annual HIV and CNS Day. Jo, the floor is yours.
Thank you very much. Next slide, please. You've already heard more or less what I do, so I'll move straight on. This is my perspective, because I'm very aware that I do not have the medical training, the psychological training, or indeed the experience of other speakers. But what I do have is the perspective of someone who is living with HIV and who understands communications after some 40 years of working in it. Next slide, please. As has been said by others, we are all different. So there is no such thing as a homogeneous group of old people or older people living with HIV, because you can be older but have actually contracted HIV when you are older. There are people I know who are women who came out of a divorce, and that's when they contracted HIV. The same is also true for men whose relationships have broken down. And so they become a statistic amongst the over 60s living with HIV, but not prepared for it by coming from the very early days. Also, our relationship to others in society is going to differ. Whether you happen to be a parent, you will have a family or have had a family. You will have friends. You will go out, even if you only see people in a local supermarket. If you're here today, you're probably an advocate. You're probably someone who wants to change things for the better, but you will always be someone who has a tricky little virus that decided to make its home in you. Next slide, please. These side effects have been mentioned by others. The menopause's effects are grim and are sadly not recognized in the way that they should be. Other things that build up over time are weight, mobility. If you weigh too much, your movement becomes limited. Your movement becomes limited, you're going to put on weight. It becomes a vicious circle. Frailty describes people who fall over frequently, and I seem to be becoming one of those as I live with neuropathy, which many people who are listening today may do as well. It's quite prevalent to have paralyzed nerves in your lower feet, legs, or hands as a consequence of the HIV virus, not simply, as is often thought, as a side effect from having taken earlier HIV medications. And money is not easy to manage for anyone today. For people with HIV whose work opportunities may be limited, then it's worse. And that in turn leads to a lack of independence. You have more money, you have the ability to go on a holiday, you have the ability to go and see a good film or go to the theatre. And if you can't do those things, your self-image is not great. You see yourself as a sort of boring, aging wreck. Next slide, please. And if you see yourself like that, you may well become isolated. Why should you go and meet any other person? Why would they be even slightly interested in you? And we should remember that not everybody we know, maybe not many people we know, comes from the HIV tribe. The world is full of people, as we should remind ourselves, who do not know about HIV, and they certainly don't live with it. We know that it can really seriously affect our ability to make friends and lovers. I seem to remember them, but it's a little bit of history these days. And what we look like. I've always felt that God was exceptionally kind in that when I look in the mirror now, my eyesight has deteriorated as my age has increased. So I do not find it possible to see all of the wrinkles unless I wear the right glasses. Next slide, please. But stigma, as everybody has told us, and as we who live with HIV know, it's just there. We can't forget about it because nobody else does. Next slide. It's how others see us that shapes a lot of how we see ourselves. Self-stigma, the term that's thrown around now. But where did that come from? It came from other people. Where did their thoughts and perceptions come from? Mainly fear, scaremongering, being scared of HIV because of its history. And that came ultimately from media reporting. Next slide. And it echoes around. It echoes around now. In the UK, there was a very famous ad which showed a tombstone which crashed down, saying, "Don't die of ignorance." And almost every time there is a new HIV story, that iconic tombstone fills our screens again, just in case we forgot that it was, emphasis was, a death sentence. Next slide. I handle the media for the British HIV Association. I have been the media, both in print and broadcast. I know that stories are not about information. The number of people I know who say, but that's not right. Don't they want to get it right? No. What is it about? Getting viewers. Viewers for the news as well as for TV dramas or entertainment shows, or to sell newspapers. It is not about informing the public. I took a few screenshots last week so that they would be current, as opposed to picking what might be out there, which arguably could mean I was being biased in what I shared with you today. The first image is about Liverpool allowing people that live in Liverpool to order PrEP online at no cost, which is good news. But how is that for people who haven't got HIV? Do they know anything about HIV prevention? Friends of mine have telephoned me saying, "Hey, Joe, have you seen? There's a new thing, it stops HIV." What they do not realize is this is not a cure. This is something that prevents HIV transmission. The second story is about a man, and the BBC is being blessedly cool about this, who was convicted over, ouch, infecting other person with HIV. That particular story could have been far more dramatically reported. I know because I worked with other people, other organizations, to try to, and to a great extent, we did succeed in minimizing the ingredients of that story so that it wasn't another homophobic piece, so that it didn't go on about chemsex, so that it didn't go on about promiscuity. So while it's not ideal, it's not as bad as it could be.
1 minute, Joe.
Tilda Swinton is talking about the number of people she knew that died, so 43 funerals. That's a lot of people in 1994. The game-changing drug, next slide, is about the availability in the UK of cabotegravir. We all know about the UK AIDS Memorial Quilt. This is about the exhibition for it, shown at the Tate. Unfortunately, the message that comes out of that is again death. Next slide. Survivor stories can be good. This, I was told I had between 3 and 9 months to live. The negative is implicit in that headline. Next slide. What can we do about it? Next slide, as I'm running out of time. The People First Charter, which some of you may have heard of, is about the use of words, transmission, not infection, and about shaping content. Next slide. Do talk about people living with HIV. Don't talk about HIV victims. Do talk about HIV as a long-term condition, and please do not imply that only gay men get HIV. Next slide, nearly there. We can all help with healthcare by contributing to research. Next slide. Next slide. We've talked enough about mental health. Next slide. The most worrying thing is to learn about neurocognitive disorders from HIV affective transmission. But what can we do for ourselves? Changing our own perspective. For me, walking in nature has an amazing effect. Green spaces, peace and independence. In that way, I can transform my experience of HIV, even if I cannot transform the experience of others.
Okay.
Thank you.
Thank you, Joe. Thank you for your presentation. I think it connects perfectly well with the previous presentations. Pass it on and move on to our next speaker, which is Kate Moortsen. Kate is the interim co-executive director at Realize, which was previously known as the Canadian Working Group on HIV and Rehabilitation. For the last decade, her work, including research, advocacy, and education, has focused on the health and well-being of aging and older people living with or vulnerable to HIV. Kate is currently the nominated principal investigator on PANASHI, which is a community-based research project assessing the health and social care needs and preferences of people living with HIV over the age of 60 across Canada. And finally, she's also one of the co-authors of the Glasgow Manifesto and a friend. Kate, the floor is yours.
Thank you so much, Mario. Good afternoon, everyone. Thanks for inviting me to be part of this important discussion. So I'm going to be talking about the Canadian context. I realize that makes me a bit of an outsider to this group, but I think we'll see a lot of overlap with what the other speakers have mentioned. As Mario said, my name is Kate Moortsen. I'm the interim co-executive director of Realize, which is a national not-for-profit organization in Canada, which is focused on optimizing the health and well-being of people living and aging with HIV and other episodic disabilities. So what's unique about Realize is that we bridge the traditionally separate worlds of HIV, disability, and rehabilitation. So we think about some common challenges to social inclusion that face people living and aging with HIV, but also that face people with other health conditions like mental health issues, multiple sclerosis, long COVID, and others. As Mario mentioned, I'm also the lead researcher on the PANASH project. So PANASH is a community-based research project which aims to collect information from people living with HIV who are over the age of 60, and to gather that information about their current and anticipated health and social care needs and preferences. So the realities facing people aging with HIV in Canada that I'm going to outline in my presentation today are largely based on data collected during the first phase of our PANASH project, where we conducted qualitative research with 73 older people living with HIV in Ontario, which is Canada's most populous province. So I'll first address mental health. And one of the 3 key themes that was identified through PANASH Ontario was that of uncertainty and the anxiety that often accompanies it. So this is in keeping with earlier Canadian research on HIV and aging, like the work of Patty Solomon and her colleagues, which outlines 7 sources of uncertainty for this population. And you can see that in the schematic on the slide. In PANASH, uncertainty pervaded the day-to-day lives of many older adults living with HIV. And the sources included not knowing how well they would feel day to day, constantly having to adjust to new limitations when additional illnesses popped up, and a lack of clarity about whether changes in the body or the mind were attributable to HIV, to medication, or to normal aging. Whether they'd be able to meet their day-to-day basic needs for food and shelter was an additional source of uncertainty, especially for many who lived on a fixed income. And this is definitely reflected in many other studies that have been done in Canada. Uncertainty was also related to the future. So many people reported changes in memory and concentration and had questions about whether they would expect further decline, and if so, what the impact would be on their future independence. Unknowns related to future care and support were also raised. But one thing I want to point out about resilience, as the other speakers have so beautifully highlighted, is that really it was the inability to exercise control over meeting current or future needs, either due to lack of finances, lack of social support, or lack of information, that really contributed to the negative feelings associated with this uncertainty. So financial insecurity was one of the most pressing psychosocial issues facing older adults living with HIV in Panache. So out of 73 of our participants, only 11 people reported working, and the most common source of income was one or more benefits programs. Many people were struggling to afford adequate food, housing, and services and supplies, and worried that the gap between their income and their expenses would continue to get wider as they aged. For those who had been living with HIV long-term, financial resources were especially scarce. We also noted several instances where participants shared conflicting information about what benefits and incomes they were entitled to. And these misunderstandings indicate the array of income support and benefit programs is very complex and difficult to navigate. So all this to say, financial insecurity was a major stressor for this population. Another recent study that we did also showed that service providers in community-based HIV organizations felt ill-equipped to respond to financial insecurity among people aging with HIV. Among other things, they cited receiving little or no training about financial empowerment resources and a propensity for organizational responses to center on short-term aid as opposed to more sustainable solutions. The second issue I'll focus on is barriers to accessing supportive spaces and care, including a loss of peer support and community spaces, lack of informal caregiving supports, and worries about finding stigma-free services. And these are things you've heard from all of our previous speakers. These barriers are often exacerbated by a history of trauma and loss among those living long-term with HIV. So folks in Panache, Ontario reported that for a number of reasons, their social networks had been compromised and had not necessarily been rebuilt over time. In contrast to that was what was reported as helping to provide with a sense of purpose and fulfillment was staying engaged within their communities, seeking out opportunities for learning, and occupying a significant role in their social network. Unfortunately, we've seen a major shift in the HIV response in Canada from a focus on support for people living with HIV to an emphasis on prevention and treatment only. The first HIV organization in Canada, the AIDS Committee of Toronto, is permanently closing its doors in March, signaling the end of an era in peer support and community-led response. But it's unclear whether aging organizations will fill this gap. We at Realize recognize that there are similarities in experience between HIV, aging, and disability, as you can see in this Venn diagram, but policy remains very siloed. People aging with HIV may exist at the intersection of all three. So one of our recent policy projects documented this gap. Our analysis aimed to uncover the layers of ableism and ageism embedded within Canadian sexually transmitted and bloodborne infection policy, as well as the lack of attention paid to HIV in policies focused on disability and aging. Based on our findings, there's little overlap between the responses to HIV, disability, and aging, and we recommended more cross-sectoral collaboration across data collection, policy making, service provider education, and stigma reduction efforts. We've also been aiming to fill an information gap that's rooted in ageism by creating two toolkits, one for older adults and one for service providers, which address the sexual health needs of aging people. These adaptable resources are available on our website in 6 languages and are free to use by organizations globally.
1 minute, Kate.
Thank you. So in good news, emotional support from close friends, peers, virtual communities, family, and partners was readily available to many of our Panache Ontario participants. And in fact, seeking support from others was one of the most commonly reported mental health coping strategies. But this doesn't always equate to practical support. Almost 60% of our study participants reported living alone, and self-sufficiency was a necessity for those who didn't have access to hands-on support for things like transportation, activities of daily living, and the like. And that is incompatible with the strong preference for aging in place as opposed to in residential aging care. I'm just going to highlight this study by Jacqueline McMillan and colleagues that shows that there are high levels of worry, about over 60%, with people worried about their HIV status not being kept confidential when receiving home care or long-term care, and being worried about other residents finding out their status and treating them differently. So in order to respond to some of those concerns, we've also undertaken work in 2 areas. The first is a training course for healthcare providers and students in these fields to raise their awareness of the lived experiences of people aging with HIV and preparing them to provide culturally appropriate care. And the second is a project that's aiming to build relationships between the HIV community and the long-term care sector, including helping long-term care homes create policies or commitments to care, which would help ensure equity and inclusion for people aging with HIV. Thanks so much, and I look forward to discussing these more in the rest of the webinar.
Thank you, Kate. And thank you for highlighting what do you call the changing landscape in the HIV community at the moment, which is true. Many organizations are closing. Those organizations which were providing, peer support to, to people, and this becomes particularly relevant for older people living with HIV. Well, I'll move on to our next last speaker, which is Anton Bazenko. Anton is based in Brussels, formerly from Kyiv, Ukraine. He has a master's degree in international economy. He's a globally known activist of the community of people who use drugs and people living with HIV and lived experience with hepatitis C. Since 2010, he started his work in HIV and TB service, harm reduction and advocacy field in local and national NGOs in Ukraine. Since 2013, he's worked for International Alliance for Public Health, and he's author of different articles, guidelines, and publications for communities and professionals. And he's also a member of the community delegation of the Global Fund. And finally, since 2025, he's the executive director of the International Network of People Who Use Drugs, Input. Anton, the floor is yours.
Thank you, Mario. Natasha, could you please share my slides? I think it would be better if you would. Yeah, so I think I can start while it's downloading or opening. Thank you, Mario. Thank you very much for this, and thank you, EATG, and thank you very much for this opportunity, and greetings to everyone joining us today. Sorry, is it okay, or should I open from my side because we can't see the slide? No.
Anton, I'm already sharing my screen.
But we see your screen, but not the slides.
Don't you see the presentation?
No.
No, we don't see it.
Yeah, if you can just open. Well, I can do that for myself, but I decided that I would better focus on my speech if you will switch than myself.
Mario, the presentation is not visible, yes, because I have.
No. Okay. Let's just not probably not.
We can't see it.
Okay, then let's Yeah, I'll share it from my side. Can you see that now?
Yeah.
Yeah. All right. So, my name is Anton Basenko, and thank you, Mario, for good introduction. In the sake of time, I would be faster. Well, I speak today, as you can understand, as someone who has lived through the drug use. My experience with drug use, and I'm still using drugs, is more than 25 years. I'm living with HIV since 2003, so it's also more than 20 years. And yeah, though I have cured hepatitis C, but I lived with this disease like 16 years, I think, or so. And the realities of criminalization, unfortunately, but also as someone who has seen our community's resilience and leadership grow over the decades. And that is why my focus today, and I would like really to extend the agenda from the aging topic, which sometimes sounds like more medical or medical social, but I really want to bring some policy and contextual things and extend the agenda and the information to the reality of criminalized communities like people who use drugs, who's of course has its own specificity, but at the same time has interrelation and cross-cutting issues for all HIV-affected populations. So my focus today is the intersection of aging, mental health, and resilience among people who use drugs and live with HIV. Not necessarily living with HIV, but mostly in what it means to build the systems that don't just keep us alive, but help us age with dignity and power. So who we are quickly. Formally, Input is a member-led network. Since the latest membership system change, actually our members are 8 regional networks. So every region of the world, like Pacifica or Africa, we have 8 regional networks: African PUD, NAPUD, NPUD, and International Network of Women Who Use Drugs. Those are 9 members of Input. But as a global movement, given that there are not only regional but country networks, we are connecting global movement like 40 plus. I think today is closer to 50 drug user-led networks. We were created to challenge stigma, criminalization, and exclusion, and to advocate for the health rights and dignity of people who use drugs. And as our community ages, and there are specific issues of aging which not necessarily linked with HIV, but linked with drug use. And the question before us is changing. It's no longer only about how to survive, but how to live well and age well while carrying the history and trauma of HIV and prohibition. Just a little bit of a global context of drug use and market trends, let's say. So you can see the estimated 316 million people aged 15 to 64 worldwide use drugs. So it's roughly 1 in every 17 adults. And drug use is increasing across all the regions, with opioids and stimulants driving much of the harm, while cannabis remains the most widely used substance. The global cocaine market beating all the records, plus 68% since the previous World Drug Report, and the cocaine market reached more than 3,700 tons of manufactured cocaine. And the quality of cocaine is improving when the quality of heroin today is getting worse. The Global State of Harm Reduction 2024 shows that harm reduction services, which are so life-saving and so critical to support, to resolve the drug use and drug dependence issues from the public health perspective, and to support people who use drugs, shows that harm reduction coverage remains dangerously uneven. Only 93 countries from more than 200 have needle and syringe programs, 94 offer opioid agonist therapy, and only 18 have drug consumption rooms. And these numbers mean that millions of people who use drugs, including many aging with or without HIV, continue to live without safety nets, access to care, or legal protection. And it reminds us that the health of our community is a policy choice, not an inevitability. Oops, why it's not? Okay, oh, yeah. Aging. One of the least discussed realities is that our communities is getting older, and many of us who started using or injecting drugs in the 80s or 90s, in my case it's mid-90s, teenager age, are now in our 40s, 50s or 60s. We are living longer thanks to antiretroviral therapy and harm reduction progress or opioid agonist therapy, but it's really generations of people grown up with the drug use in parallel with using of ART, so it can be an issue of polypharmacy and other complex health and social challenges, comorbidities, longer injection duration, stigma, reduced service access, and other chronic health conditions, cumulative trauma and mental health strain, ageism, which is also layered on top of drug and HIV-related stigma, and the deep sense of isolation as peers and friends pass away. So services, unfortunately, have not yet adapted to this demographic shift, and in most countries, aging with HIV programs focus on the general population or other key populations, but not on people who use or inject drugs.
Anton, you have 2 minutes.
Oh my goodness. Okay. Then just to remind you, the global context where we are is rising authoritarianism, funding crisis, and shrinking civic space. But yet communities continue to resist and innovate. You can read our report to find the effect of recent US funding cuts on the services of harm reduction and community of people who use drugs. And the data is very clear that the most affected things is peer-led and outreach work, which if you exclude this element, it's in fact excluding the total model of harm reduction, including the mental health services. But yet, despite all of this, our community continues to resist, organize, and lead changes. We know how to monitor and how to bring the evidence for our advocacy. So I'm sharing some of the key publications and key tools, which is CLM framework. We know how we see decriminalization. We know how to do research and policy engagement, and we are recognized by UN, WHO, and the Global Fund. What is important? It's a real meaning of inclusion. And inclusion is not only the invitation, it's really decision-making power. So to raise the aging issues, we have to be in things like CCM or other working groups or decision-making bodies. It's a direct funding streams for community, and one of the examples is the Unity Fund, and of course, accountability to our communities. This is second thing why investing in communities is smart, ethical, and effective, and is very important. And you can find this joint position paper of all key populations, global networks, Input, Impact, NSWP, and GATE, which shows all the things we are talking about today. This is a little bit about our vision forward. Of course, decriminalization grounded in human rights, sustainable funding for peer-led networks, and global solidarity against repression and stigma. The rest of things you can find in our strategic plan for the next 5 years. And of course, I think we have to be loud with our call to action. Governments should end criminalization. Donors should fund community, including community of people living with or affected by HIV, fund our community leadership and community-led responses. And allies should stand beside, but not above us.
Okay.
Yes, and my last slide, we survived epidemics, prisons, and social exclusion. Now we deserve to age with dignity, connection, and joy. Aging is not the end of activism, it is the continuation of it. So thank you for your attention and for recognizing the people who use drugs and our voices as one of the central in the conversation on aging, HIV, and mental health. Thank you.
Thank you, Anton. Sorry, we're very, very, very late. I'll just, I don't think we have the possibility to have a Q&A, but I would just, we've had a few comments in the chat box. I will read out the comments, but of course we don't have time to discuss them further here. Sorry, but maybe It should have been a 2-hour webinar, not a 1 hour and a half. Well, one thing from Axel van der Per, who was talking about how important it is to bridge the HIV reference centers to peer support groups outside the hospitals, something we have always been supporting and talking about. Then there was another comment where we have to consider, from Ali, the significant gaps of many people aging with HIV who are digitally excluded and are being pushed online for their care, as this is an integral part of funding offers. Then another comment from Axel: for gay people, ageism is a key issue as well within the MSM gay environment, which is true and which is something, a key issue I think that we should be talking about. But also, one last from Mina: any correlation barriers to digital exclusion, which was directed to Kate Moortsen, and also from a comment from memory from Axel that chemsex in chemsex should also be mentioned, where also mental health, ageism, etc. are issues. So, as I said, we don't have time for the Q&A. I think we have to close the webinar here. So I will give a very, very, very brief wrap up, saying that as we wrap up today's webinar on mental health and psychosocial challenges, I want to take a moment to reflect on the incredible range of insights that we've heard and the great amount of content that our speakers have provided. I think we can all agree that we leave today with a better understanding of the wide range of psychological and social challenges that older people living with HIV face in their daily lives, but also with a clear and actionable steps towards ensuring a better quality of care and better quality of life for all people living with HIV. And again, a final thanks to all our speakers, Amy, Giovanni, Maria, Joe, Kate, and Anton, for sharing their time and expertise. And of course, thanks to all of you, our audience, for your engagement throughout the session. I'd also like to extend my gratitude to the EATG team, and a great thanks to our fantastic Vladimir, allowing us to reach a wider Russian audience in the ICA region with his translation. One last thing, don't forget to fill out the evaluation form that will pop up on your screen at the end of the session. Your feedback will help us improve future events. And keep in mind that the materials and the slide decks from today's presentation will be available on EATG's YouTube channel starting tomorrow. So thank you all for your attendance. And bye-bye to all.